Hello and welcome to Chapter 17, Hemolytic Anemia Membrane Defects. So hemolytic anemias we've talked a little bit about in the last few chapters in hemoglobinopathies and thalassemias leading to destruction of the red cells. We also have a few other chapters coming up that are also considered hemolytic anemias. This week we're just going to talk about the membrane defects, and that can cause hemolysis. So you're used to seeing the red blood cell as a normal erythrocyte, 7.5 microns, and a nice discocyte shape where it's indentation of the middle, and you can see central pallor, 1/3 of the red cell. Now the membrane is so integral to the actual structure because of the components that it has to protect. The membrane is composed of proteins and lipids. It maintains the stability and its shape. It really needs to be able to be deformable going through all of those cavities and venules throughout the body. It also allows for selective permeability through the cell to maintain that shape. Vertical interactions are perpendicular to the skeletal protein to the plane of the membrane. The interactions between the lattice, skeletal lattice, and its attachment to integral proteins and lipids are important because they stabilize that lipid bilayer membrane. Any defects in this could cause an uncoupling of that lipid bilayer. And as you see in this image, you see the normal discocyte. Then portions of selective loss will happen to that bilayer, leading to a decreased surface area to volume ratio and net loss of the membrane, leading to the formation of a spherocyte and eventually hemolysis of the red cell. Now, horizontal interactions are parallel to the plane of the membrane. Here, these interactions provide the stability and forms a tetramer of skeletal protein and has a spectrin heterodimer head-to-head association. Now, any defects in this disruption of the lattice causes membrane destabilization, elongation, as you see from that cell in B, and can cause cell fragmentation and the formation of poikilocytes. Now, for lipid composition abnormalities within the membrane, these are defects that affect the composition of the membrane lipid bilayer, causing acanthocytes or stomatocytes. So in a normal red cell membrane, you have equal amounts of free cholesterol and phospholipids in the membrane. Any excess of free plasma cholesterol accumulates in that bilayer and causes the expansion of the outer face as compared to the inner. Now here you have the formation of characteristic acanthocytes. Now table 17.2 is a very good study tool to kind of guide you as to the umbrella of conditions of membrane disorders on the left. The inheritance pattern is not something you will be tested on, but the defect and the cause of the deficiency you'll have to know, as well as the type of vertical or horizontal protein interaction, and any erythrocyte abnormal morphology that you would see on the smear. So let's talk about the first disorder here on the list, spherocytosis. So hereditary spherocytosis is a common inherited membrane disorder. It affects 1 in 2,000 Caucasians. It has an autosomal dominant or recessive type of modality. Here you have a mild to moderate hemolysis, red blood cells deficient in the membrane protein are usually abnormally permeable to cations, and there's problems with the deformability and permeability of the cell. This is usually caused by a defect in spectrin or ankyrin, which weakens the connections and uncouples that inner membrane skeleton and the outer lipid bilayer. Shedding portions of that lipid bilayer forms those microcytes or spherocytes. And this disorder is of vertical protein interaction problem. So you have membrane loss, you have a decrease in surface area to volume ratio, your changes in shape from a normal discocyte change to a spherocyte, which is increasing in the cytoplasmic viscosity and reduces cellular flexibility. Eventually, these cells will be trapped in the spleen. They lack flexibility, so you will have them hemolyzing. And here you have a classic picture of a patient with hereditary spherocytosis. Now you see many densely staining spherocytes. They have no central pallor, they are darker in color, and look at that compared to that small lymphocyte, it is quite small. As for the severity, usually 25% compensate for this hemolytic disease where no anemia or little jaundice or slight splenomegaly happens. Because your spleen is destroying all these red cells, it can get enlarged. If you have the homozygous type of inheritance pattern, this can be lethal. But most of the patients are partially compensating and they appear asymptomatic. Hemoglobin levels can be normal or decreased. In infants, you'll see it a little bit lower, and reticulocytes will try to compensate here by having usually a greater than 8% output on your peripheral smear. Now, spherocytes are not always prominent. The young red cells are usually normal shape, but as they grow through the circulation and through the venules, you will see that over time, they will form these spherocytes. And with the bone marrow outputting all of the reticulocytes, you will definitely see polychromasia. Your red cell indices, if you have a lot of spherocytes, will bring down your MCV to a low, normal, or decreased level. Your MCHC is normal, and here you have a characteristic greater than 36 grams per liter of your MCHC, which is technically classified as hyperchromasia, but again, we don't put that as a classification, but on your CBC report, you will definitely see a marked elevation in your MCHC. In the CBC in your peripheral smear, you will do a reflexive test called an osmotic fragility. This measures the red cell's resistance to an osmotic stress. So here you have cell volume, surface area, and membrane function of the cell to consider. So with the red blood cells incubating in various concentration of sodium chloride, the spherocytes cannot expand as normal red cells do because they have decreased surface area to volume ratio. So you have increased fragility, and then the lysis begins at higher concentrations of sodium chloride. You incubate this test at 37 degrees for 24 hours. It increases the sensitivity, and it's the most reliable assay for the diagnosis of hereditary spherocytosis. Now, for therapy, usually mild forms involve no therapy at all, but if you do have a homozygous state and you have a very enlarged spleen, you might have a total or partial splenectomy as a therapeutic measure. Now, next, let's move on to hereditary elliptocytosis. Here you have an autosomal dominant inheritance. It's a worldwide incidence. The heterogeneous form, degree of hemolysis, again, depends on the severity. And the prominent cell finding that you're going to find in the blood picture would be an elliptocyte. Now, there is a defect in one of the skeletal proteins here. The elliptocyte shape is acquired in circulation over time. Red cells subjected to the shear stress of circulation acquire this elliptical shape. Normal red blood cells revert to the biconcave shape, but in hereditary elliptocytosis, they remain elliptical. Now, this is a defect in the horizontal membrane protein interaction where you normally see a deficiency of glycoprotein C. You have abnormal anion transport and an increased affinity to ankyrin. Here, the skeletal disruptions lead to the elliptical shape, and you have decreased association of spectrin dimers to form tetramers. Alteration in the shape occurs only. Usually the red cells have a near normal lifespan. It might be slightly decreased. Elliptocytes with membrane fragmentation have a decreased cell surface area and are reduced to deform within the circulation. So if this does happen, you will have a shortened lifespan. Is a peripheral blood picture from a patient with non-hemolytic hereditary elliptocytosis, where you're seeing almost 100% of these cells being elliptocytes. And again, we give you a nice couple images of the lymphocytes here to compare the size of the nucleus to the red cells in the surrounding picture. Now, 90% of cases don't have overt hemolysis, but it can be asymptomatic to severe clinical disease. Severe hemolysis with this usually involves fragmentation and additional poikilocytosis. Now, you usually have over 25% of the cells being elliptocyte, and a lot of the times with asymptomatic variants, your hemoglobin levels are usually over 12. You may see an elevated reticulocyte count, again, if there is hemolysis. Some peripheral pictures with hemolytic episodes have bizarre poikilocytes, schistocytes, spherocytes, and microelliptocytes. This peripheral picture here, so the other image was a peripheral blood patient with a non-hemolytic, and here you have a hemolytic hereditary elliptocytosis, showing your schistocytes as well as the elliptocytes present. Now, therapy for these variants can be splenectomy, or if they're asymptomatic, no therapy is needed at all. Conditions are hereditary pyropoikilocytosis. So it is kind of a severe form of a horizontal type of interaction where you see there is definitely a lot of schistocytes, and as these cells elongate, they start to form and pinch off. Now, it is a rare recessive disorder. It is a subtype of hemolytic or hereditary elliptocytosis. And in infancy or early childhood, the hemolysis is more severe, and you see extreme poikilocytosis. So with the thermal stability, you have normal cells that fragment at 49 to 50 degrees Celsius. In this condition, cells fragment at 45 degrees Celsius when incubated at 37 for greater than 6 hours. The problem here is a deficiency of alpha spectrin. Now, patients can be homozygous for spectrin mutations or doubly heterozygous. There is a disruption of the skeletal membrane lattice that causes the destabilization and fragmentation and eventually poikilocytosis. So here is a peripheral blood picture from a patient with HPP. The hemolysis at birth is present. You might have hyperbilirubinemia with all of the hemolysis going on too. In this case, for babies, they need exchange transfusion. That means a full exchange of their blood for normal blood, and they need phototherapy to decrease the bilirubin present. Now, therapy could lead to splenectomy, especially if the hemolysis is very severe. Now, here you have a striking poikilocytosis. You have budding fragments, microspherocytes, elliptocytes. You might even see some cells shaped as triangles or just a bizarre form. And because you have a lot of these fragments, your MCV could be as low as 25 to 55 femtoliters. Now we're going to do an osmotic fragility test here as well. Now they will be abnormal, especially after incubation, because the thermal sensitivity test increases fragmentation. And here is a peripheral blood smear from a patient with HPP after incubation of 10 minutes, where you see there is great fragmentation of the cells happening because of the increased sensitivity. Now, hereditary stomatocytosis syndrome is a rare autosomal dominant membrane disorder and a hemolytic anemia that causes abnormalities in cation permeability in the red cell membrane. There are two types, one where cells are overhydrated or when cells are dehydrated. Conditions of overhydrated versus dehydrated stomatocytosis. So overhydrated cells are abnormally permeable to sodium and potassium, and intracellular concentrations of cations increase, where water enters the cell and causes those stomatocytes. So on the wet prep, you will look and see that the cells are swollen as they're hypotonic, and they assume this bowl-like shape. Now on the stained smear, the red cells will appear with a slit-like area of pallor. In dehydrated stomatocytosis, you have a net loss of potassium. This exceeds the passive sodium influx and net sodium gain. The cell now appears dehydrated or in a hypertonic solution, and it becomes to contract and spiculate. Now here, the cells as dehydrated, the MCHC is greater than 37 usually, and you have decreased cell deformability and increased cytoplasm viscosity. So here is your peripheral picture of a patient with hereditary overhydrated stomatocytosis. Look at all the stomatocytes here, definitely a marked increase, mouth-like slit cells. Anemia here is usually mild to moderate with hemoglobins ranging from 8 to 10. The MCHC of stomatocytes are decreased, but the MCV can be increased as they're taking on more water. You might have 10 to 50% stomatocytes, in some cases more. You have increased osmotic fragility and autohemolysis due to these cells. In dehydrated stomatocytosis, you'll see target cells, red cells with hemoglobin puddled at the periphery. You might have a slight increase in MCV or MCHC and decreased osmotic fragility. Now for therapy, splenectomy is not needed. Now let's move on to acanthocytosis, where this is abnormalities of the lipid membrane. They can be usually acquired or hereditary, caused by liver disease or Abetalipoproteinemia. Now the concentration of plasma lipids here increases where the red blood cells acquire excess lipids. They expand the membrane, causing acanthocytes, leptocytes, and sometimes target cells. We're going to start with a patient with spur cell anemia due to a liver type of condition. You have acanthocytes here and spherocytes as well. Now this can be due to a severe hepatocellular disease, usually from cirrhosis, where you have an increase in lipoproteins. There is excess cholesterol in the membrane. This increased cholesterol to phospholipid ratio, the cells flatten with scalloped edges. You could cause leptocytes as well. You have decrease in your membrane fluidity and definitely decrease in deformability. Now, after repeated splenic passages, the acanthocytes occur, or spur cells occur. which are just spike-like projections. Here, your peripheral blood, you have moderate to severe type of normal cytic normochromic anemia. Your hemoglobin can be as low as 5, with the reticulocyte increased up to 15%. You could have 20 to 80% acanthocytes. You may see spherocytes or echinocytes. Another type of problem with your proteins and cholesterol or lipids is Abetalipoproteinemia. This is a hereditary type of acanthocytosis. It's rare, autosomal recessive, and usually caused by an absence of serum beta lipoprotein, which leads to a low serum cholesterol, triglyceride, and phospholipid, which increases the cell's cholesterol to phospholipid ratio, usually from a defect in the synthesis of lipoprotein B. Now here you have minimal hemolysis, little to no anemia. You might have a normal to slight increase in your reticulocyte count. The next condition is lecithin cholesterol acyltransferase deficiency, which is a rare autosomal recessive disorder. It affects the metabolism of HDL, and it usually has a young adult onset. LCAT indirectly regulates the amount of free cholesterol within the cell, and if you have a deficiency, you usually have a mild type of hemolytic anemia and numerous target cells loaded with cholesterol. Now the last condition here is paroxysmal nocturnal hemoglobinuria. Now usually there's no defect with the membrane itself. It's usually a red cell that's abnormally sensitive to the lysis by complement that is attached to the cell. There's intermittent bouts of intravascular hemolysis in this classic pattern, and it's called a nocturnal hemoglobinuria because it's likely to happen while patients are sleeping. It is an acquired stem cell stomatic mutation where there's an abnormal clone of differentiated hematopoietic cells. Your red cells and platelets and neutrophils may be affected, where you have the binding of abnormally large amounts of complement. The abnormally sensitive to lysis because you have a deficiency due to a lack of glycolipids. Now this occurs mostly in adults, and there's 4 types of basic disease manifestations. From this, you can have hyperhemolysis, you can have venous thrombosis, infection, or bone marrow hypoplasia. The intravascular hemolysis can occur with hemoglobinuria, often associated with sleep, associated with infections, vaccinations, surgery, or ingestion of iron salts. With venous thrombosis, you do not want your blood to clot within the venules. This is a very common cause of death. And infections are caused if you have a decrease in your neutrophil white count. Now, over time, this can lead to your bone marrow stopping producing normal cells, which leads to a hypoplasia. Now, here you see the laboratory findings of a peripheral picture of a patient with PNH. You see here some nucleated red blood cells and some schistocytes, as well as a little bit of polychromasia. Now you can have a severe anemia here where your hemoglobin drops 8 to 10, your red cells are normocytic or macrocytic, and your reticulocyte count can be up to 10%. And you may see nucleated red cells. Now bone marrow transplantation may be a curative approach,